Hello, participants. I welcome you to my presentation and the project of clinical key for electrical stimulation in physiotherapy and rehabilitation. So this project is funded by the Erasmus Plus program of the European Union, and the leading university for the project is Pamukkale University, and the partners of this project are University of Craiova, Ataim Mustafa Kemal University, Tashkent University, Suleiman Demirel University, Shuley State University of Applied Sciences, and Burdur Mehmet Akif Ersoy University. Also, partners of this project are Turkish Physiotherapy Association, Order of Physiotherapists in Romania, Lithuanian Physiotherapy Association, and Estonian Association of Physiotherapists. And so now we are going to talk about transcutaneous electrical stimulation in Module 2, which is currents used for electrical stimulation. So authors of this chapter is me, Dovydas Gedrimas, and my colleague Vaida Aleknavičiūtė Ablonskė in Šiauliai University of Applied Sciences, Faculty of Healthcare, and Department of Rehabilitation in Šiauliai, Lithuania. So to begin, transcutaneous electrical stimulation is a technique to artificially activate motor nerves and muscles. It can be used for rehabilitation or the restoration of lost motor function, for example, in subjects with brain or spinal cord lesions. Apart from selectively activating motor nerves and muscles, transcutaneous electrical stimulation activates sensory fibers and pain receptors, producing discomfort and sometimes pain. So definition can be divided. This transcutaneous electrical stimulation definition can be divided to main definitions. So transcutaneous electrical nerve stimulation, also known as TENS stimulation, usually for pain control. And the other definition may be transcutaneous electrical neuromuscular stimulation or transcutaneous electrical muscle stimulation, which can be used for muscle stimulation to increase muscle contraction. So, and the difference and similarity between these TENS and TES or TEN-MS is that transcutaneous electrical neuromuscular stimulation is characterized by effective muscle contraction without creating pain. So its main function is to contract muscles. While TENS stimulation creates stimulation of large diameter sensory nerve fibers without creating significant muscle contraction, and usually it is used for pain control, but not to contract muscles, to increase their function. These are the main differences. While applying transcutaneous electrical stimulation, two main aspects are important. The selective activation of specific muscles to generate the intended motor function, and a comfortable stimulation to increase patient acceptance of electrical stimulation. So, in other words, the location of electrodes is important, and parameters of stimulation also is important to get maximum results. Usually, clinicians try to minimize discomfort caused by electric current by optimizing stimulation parameters, electrode location, and electrode size. So, for bigger muscles, we usually use bigger electrodes. For smaller, for example, forearm muscles, we should use smaller electrodes. And the main parameters are pulse frequency. Frequency usually is described for TENS stimulation is usually lower than 200 Hertz. I should mention that Hertz are the main parameter of frequency, and it represents how many pulses of electrical current occurs during 1 second. So in this case, 200 hertz are 200 impulses per second. If it would be 5 hertz, so that means that it would be 5 impulses per second. Usually, the higher the frequency, the more gentle feeling of the stimulation occurs. The second parameter is pulse amplitude, usually less than 70 milliamperes. So it can also be called intensity of stimulation, and it represents how strongly the stimulation will be felt by the patient, and it should be carefully chosen not to cause pain or discomfort or unnecessary muscle contraction if there is no importance for that. Other parameter also which is important is pulse duration. So it is measured in microseconds, usually between 50 and 250 microseconds. So as I mentioned before, frequency is measured in hertz. So how many impulses in 1 second, and pulse duration shows us how long is one duration of these, in this example, 200 in these 200 impulses. So if we have 200 hertz, so we have 200 impulses during 1 second, and we can change each pulse of this stimulation, and we can make them shorter or longer, depending on what effect is needed. And pulse pattern, sometimes termed mode, and including continuous, burst, or modulated patterns. So continuous is quite simple. Electrical current goes continuously without any pauses. Bursts are usually in impulses, and modulation can be made in frequency. So the frequency can change during the stimulation. Pulse duration can change during the stimulation. And the main categories of TENS, there are low frequency TENS. So it is consistently defined as the delivery of pulsed current of 10 hertz or less. So it's quite, so it's we don't use many hertz for low frequency stimulation. Low frequency trains or bursts of a high frequency pulsed current. So it can be described as burst mode TENS. When very low frequencies are used, TENS specifically targets sensory nerve fibers and does not activate motor fibers. Therefore, no discernible muscle contraction is produced. So you should remember that low frequency is lower than the 10 hertz. Acupuncture-like TENS is attributed to low frequencies as well. It is described as low frequency, usually 2 to 4 hertz, and high intensity TENS. So it uses low frequency but high intensity, evoking tolerable but painful sensations. In essence, acupuncture-like TENS is thought to help close the gateway of pain transmission and hence result in a reduction of pain. And high-frequency TENS is defined as a pulsed current with the delivery of high frequency, so from 50 to 100 hertz, and low-intensity current, evoking a comfortable, non-painful tingling sensations. High-frequency TENS is usually related to the gate control theory that a high-frequency and low-frequency stimulation of large diameter A-beta afferents results in a segmental inhibition of the transmission of nociceptive information at the dorsal horn level. It should be mentioned that high-frequency TENS is not always applied at a low intensity, and low-frequency TENS is not always applied at high intensity. So should be mentioned. And low-frequency TENS applied 10% below the motor threshold generates analgesia in humans and reduces primary and secondary joint inflammation in animal models of nociception. So 10% below motor threshold, so we shouldn't reach the muscle contraction of during this stimulation. Evidence suggests that optimal hypoalgesia is achieved using pulse amplitudes that generate a strong, non-painful tense sensation, and therefore pulse amplitude should be titrated during treatment to maintain this intensity levels. For example, if we use continuous stimulation, so sometimes adaptation occurs and patient can start feeling a little bit more gentle stimulation. In this case, we should increase intensity or pulse amplitudes to get optimal sensation. Recommended parameters for transcutaneous electrical nerve stimulation. So these are only the recommendation, but usually the main difference is that high rate tense, as I mentioned before, is 50 to 100 Hertz, while low rate transcutaneous electrical nerve stimulation is 10 Hertz or lower. Usually, pulse duration is shorter for higher frequencies and longer for lower frequencies. Intensity, so intensity should be tolerable. It shouldn't cause pain or muscle contractions. And the treatment time, so high rate tense usually is more gentle, so it can be used as long as needed. And recommendations for low rate tense is 20 to 30 minutes during one procedure. Electrode placement and size also matters. The response to transcutaneous electrical nerve stimulation is also influenced by the site of stimulation according to the placement of electrodes. Best practice guidelines suggest that electrodes should be placed on healthy sensate skin so that the tense sensation covers the painful area. This is achieved by placing electrodes directly over or bracketing the painful site. So in this picture, we can see an example of bracketing technique. So if, for example, pain is felt here in the center of these electrodes, so we should place electrodes around this painful area, and we connect electrodes that electrical current travels across this painful area. So this electrode should be connected to the lower here, and this electrode should be connected to the lower here. So now we have electrical current going through this painful area and decreasing pain. So this is bracketing technique of painful site. It should be mentioned that usually bigger electrodes are used on larger muscles or larger pain areas, while smaller electrodes can be used on smaller pain areas or muscles. Elements that are too small might not be effective on persons with thick fat layers, because the large current spread within the fat layer prevents the current to reach the motor nerves lying deep. When evaluating various parameters of pain, maximal tolerable sensory or motor threshold, larger electrodes are significantly more comfortable and produce the higher force when compared with the smaller electrodes. Usually it is maybe more important when we try to contract muscles with electrical stimulation help. So larger electrodes help to make a sensation more comfortable than the small electrodes. Another effect of small electrodes is the generation of high current densities, which may be uncomfortable, indeed painful, and can limit the effectiveness of TENS. So if we have small electrode, the current density is quite high in this small area. If we have bigger electrodes, have the same current but in wider density, and it is felt quite the feeling is more gentle. However, not only the current density influences the perceived comfort during TENS, but also the electrode size and stimulation parameters. For example, when stimulating the tibial nerve, larger electrodes could deliver current with comfortable sensations, while smaller electrodes generated much more pain and gave the same stimulation effect. So if we have the same effect, we can try to use bigger, if it's possible, bigger electrodes to make feelings more gentle. So it is an example of electrode placement for low back pain. So usually in the if pain is spinal origin, so we place electrodes near the spine and connect them. That electrical currents travels laterally of the spine. It can reach the nerve roots and make pain signals more gentle, or make pain disappear while applying this procedure. Electrode placement for neck pain is similar to low back pain because it's a spinal origin pain also. So we place electrodes alongside spine in both sides and connect electrodes that current travels alongside the spine. In the joint pain also electrodes can be applied using longitudinal placement technique. In this example, we have a knee joint, but this principle can be applied to other joints as well. And now we're going to talk about analgesic mechanisms of TENS. So TENS reduces hyperalgesia through both peripheral and central mechanisms. So these central mechanisms of TENS, so both low frequency and high frequency TENS reduce dorsal horn neuron activity. When there is peripheral inflammation or neuropathic pain, enhanced activity of dorsal horn neurons to both noxious and noxious stimuli is reduced by both low and high frequency TENS. In parallel, there is a reduction in both primary and secondary hyperalgesia by both low and high frequency TENS. And it should be mentioned that both low and high frequency TENS have effects at the site of stimulation. High frequency reduces P, which is increased in dorsal ganglion neurons after ischius injury, and blockage of peripheral opioid receptors prevents analgesia produced by low frequency but not high frequency TENS. Thus, TENS may also alter the excitability of peripheral nociceptors to reduce afferent input to the central nervous system. Gate control theory, one of the main theory that explains how electrical stimulation helps to reduce pain. And the theoretical underpinning for pain relief by electrical stimulation of the skin was established through the publication of the gate control theory of pain by Melsack and Wall in 1965. They proposed that neural activity in low threshold cutaneous afferents would inhibit onward transmission of nociceptive information in the spinal cord and brainstem. This suggested that electrical currents could be used to stimulate the low threshold cutaneous afferents to reduce pain. The analgesic action of TENS is mediated by peripheral and central nervous system mechanisms, both spinal and supraspinal. The stimulation of large diameter afferent fibers is thought to close the gate and reduce the perception of pain. Acupuncture-like TENS stimulation stimulates A delta and C fibers and is therefore thought to achieve pain control mostly through the descending pace suppression system. And other system, other theory that explains how electrical stimulation works is opioid release theory. Electrical stimulation may also control pain by stimulating the production and release of endorphins and enkephalins. These substances, also known as endogenous opioids, act similarly to morphine and modulate pain receptors by binding to opioid receptors in the brain and other areas where they act as neurotransmitters and neuromodulators. Opioids also activate descending inhibitory pathways that involve non-opioid systems. Low-frequency TENS will usually control pain for 4 to 5 hours after 20 to 30 minutes treatment. It is effective for this length of time because the half-life of the endogenous opioids releases is approximately 4.5 hours. And low-frequency TENS should not be applied for longer than 45 minutes at a time because prolonging the repetitive muscle contraction produced by the stimulus can result in delayed onset muscle soreness. Because TENS, particularly low-frequency TENS, exerts its effects by increasing opioid levels, patients may develop tolerance to the stimulation that is similar to opioid tolerance. Tolerance causes higher doses of the intervention to be needed to produce an effect. Patients may develop tolerance to TENS by the 4th or of the 5th days of stimulation. Frequency modulation similar to those used to prevent accommodation delay tolerance to TENS induced analgesia. And to sum up, we should talk about indications for transcutaneous electrical nerve stimulation, which is acute and chronic pain, arthritis, post-surgery pain, neuralgia, sports trauma-caused pain, phantom limb pain, rheumatoid and osteoarthritis, degenerative bone and muscle diseases, lumbago, migraine. Contraindications are demand cardiac pacemaker, implantable defibrillator or unstable arrhythmia, placement of electrodes over the carotid sinus, areas where venous and arterial thrombosis or thrombophlebitis is present, pregnancy over or around the abdomen or low back, exception when electrical stimulation may be used for pain control during labor. Do not use stimulated muscle contractions for pain control, as with low-frequency TENS when muscle contractions may disrupt the healing. For example, muscle or tendon tear, overuse, or acute injuries. And precautions should be taken care of if there are cardiac disease, impaired mentation, impaired sensation, malignant tumors, areas of skin irritation or open wounds. Because of the muscle contractions, low-frequency TENS may cause delayed onset muscle soreness. And because TENS can effectively reduce pain, patients may need to be instructed to avoid potentially symptom-aggravating activities. So you can see here our team that participates in this project, and I would like to thank you for watching this presentation.